Delhi Army Hospital, RNR division. He's the head of the department, and he'll be talking to us on working in the OR.
Good evening. Thank you, BRSI, for asking me to speak on this. The aim is to discuss the application of general guidelines, that is general ophthal guidelines, in retinal surgical practice. It is not to discuss the ethics or suitability of protocols, but how we implement this on ground. I'm not an expert. We have learned because of the experience of me and team members at AHRR, whom I must acknowledge in this. This came about because we started wondering in the beginning of March that if we get a patient who's a child and who's COVID positive and falls and injures his eye, what do we do and how do we proceed? And we straight away realized that that would not be a good time to start thinking at that point in time. So we started doing these trials on what we should do. Am I audible?
Yeah.
Yeah.
Very
okay.
Yes, go ahead.
Okay. So the guidelines are derived mainly from the iOS in the IGO article, but I firmly believe that your practice situation will dictate many parts of the protocol that we'll discuss. And I'm here to discuss the practical application. So how does your practice situation affect this protocol? If you are a standalone ophthalmic OT, your situation is very different from mine, which is a multi-specialty government hospital, which may or may not cater for COVID patients also. If you have a single OT, your situation is again different from mine, which has multiple OTs, not only ophthalmic OTs, it also has multi-specialty OTs. It also depends upon what your AHU design is. If your AHU is 1 per OT, you have a different situation. And if you're sharing AHUs, then you have a different situation. And finally comes the economics and institutional philosophy, which, whether we like to admit it or not, are going to drive most of the protocols in the end when they get implemented. Because money doesn't go on trees, and institutional philosophy and healthcare worker acceptance of these protocols also matters a lot into what will finally happen. So let's walk through the OT and take a look as to what will happen. So as you enter the OT comes the first point where your practice situation starts affecting things. In an OT, you're supposed to have a donning area, a doffing area, and a designated OT. So all this stems from that initial initial paragraph, which says, please consider all patients and their attendants as COVID positive or potentially infectious. And that is the baseline for everything, and I firmly believe in that, because of the asymptomatic carriers and the poor sensitivity of the testing. So as far as I'm concerned, whether I test or not, every patient for me could be a COVID positive patient. And nothing changes my protective equipment posture, except possibly the duration of what I'm going to do, which is if I'm going to a retinal surgery versus an intravitreal injection. So if I have a single OT, my donning area would be at the entry point. The designated OT is already decided, it's one OT. Doffing area is at the exit point, and it is important to designate these areas. Most of us don't. And I know that even at this stage, we haven't got around to fully designating the doffing area. But that will rapidly change the day a COVID positive patient walks in. Multiple OTs, all this is taken away from you. For example, for me, the designated OT is by the anesthetist, not by me. And therefore, the donning area and doffing areas will also be common, and they will be designated by the anesthetists. Now we scrub and change. The important point at this point is, before scrubbing your hands, wear your N95 mask or whatever mask you'd like to wear, and your shoe covers if you're going to wear. Because once you scrub, you can't touch any of these two things. So what's the deal with PPE? There's a huge amount of confusion about what is called PPE. Some people consider that PPE is only coveralls. So that's not true. And I would like to make it clear as to what is PPE. PPE includes all the components listed here and can be scaled up or scaled down as per your requirement. So it includes a surgical mask or an N95 or N99 mask. For my situation, I consider an N95 inescapable. There are boot covers, which we will discuss. Then there is fluid resistant or impermeable gown. Now, a gown is as much of a PPE as a coverall. And in fact, our whole sort of our experiment or our trial runs were conducted just to know whether coverall can actually be worn, because all of us considered coverall as PPE at that time, for surgery or not. So I'd like to emphasize here that a gown is also as protective as is a coverall, provided you wear it along with the other paraphernalia that is supposed to be worn. However, for both of them, there are certification issues. They have to be of a certain grade, and that information is available, and they are scaled as levels 1 to 4, depending on and that's available. These standards are available. Then come the face shields and goggles, and we will discuss that too. So firstly, about the shoe covers, ankle length or below are not okay, and that's what the AIS says, and with reason. So here is an ankle length shoe cover that I wore, and you can see the minute I bend my knee, the ankle gets exposed. So it needs to go beyond the ankle, ideally up to mid calf or up to the knee. Why? Because if you are wearing a gown and your gown comes till here, the shoe cover should go above the lower edge of the gown. If your shoe cover is integrated with the coverall, that's fine. Basically, the idea is to avoid exposure of skin, so that even if there is some contaminated fluid contact, it doesn't serve as a fomite. So here was the experiment as to can we wear coveralls safely for surgery. So at points you may be tempted to laugh, but that's okay. So the first thing you realize is that this is big. So there's too little space in our usual changing areas. So you may need to go into the main OT. If you do that, then you must do it only before the patient is wheeled in. Then when you try and wear it, you realize that you have to touch the outer surface, because it's very difficult to wear by touching only the internal surface. And now you realize you're stuck. Why is this? Because you're trying to keep the coverall away from the floor and you're trying to wear it. And this is difficult. So you try, but your sleeve may be touching the floor, and now you're stuck again. Why? Because you can't find the armhole, and that's flapping around. And by now your assistants are laughing. But somehow with time you get to wear it. Right? At this point, you're not sure of the sterility. You're not sure whether it's touched anywhere or not. And you try and zip it up, and that's a potential area again where you may touch your scrubs. Now, can you wash at this point? No, you can't, because you'll splash water all over this PPE. So at this point, I realized that we should consider this coverall as possibly unsterile, right? So we decided at this point to wear a gown over it so that it becomes sterile. The other thing that bugged us was the hood. If it's not perfectly fitted, this is what happens. Sorry. So this is what happens if the hood is not perfectly fitted. But this can be improved by wearing goggles, and the goggles will push the hood back, even though it tends to keep coming onto you, right? And then again, it keeps doing this if it's loose. So as far as surgery itself is concerned, it's not so difficult. The only thing is there's a bit of heat stress. I was wearing a cheap pair of plastic glasses through which I was able to do this surgery through a scarred cornea. It wasn't a very long surgery, but I was still able to do it. So doing the surgery is not difficult. Now doffing, I want you to note the point that somebody had to release this gown tie from behind. So when you are wearing your gown, even if you're wearing just the gown, tie it on the side so that you don't need the assistant to touch it, because this is then considered contaminated. That's another little point to be considered. And when you're removing it, make sure you don't touch the outside. Now the reason for double gloves. You should wear double gloves, and note what happens when you remove the gown. This whole area gets exposed. So although this was a COVID negative patient, epidemic really blew out and we were just doing trials, it really brought to the fore certain things about wearing a coverall. Gowns are easy to wear. We are all, quite adept at wearing them. So coveralls are not easy to wear sterile. If you want to wear it, then you should wear 2 pairs of gloves, get into the coveralls as far as possible in a sterile manner, remove the outer gloves, zip up, then remove the inner gloves, use sterilium, and then wear a normal sterile glove and gown and double glove on top. Look out for the hood. I've already explained this. Also look at this exposed area. This is what happens when you don't have a good fitting hood. So you can use an external hood or you can use a surgical balaclava. Face shields are difficult for surgery and they just don't work. So goggles are the best, and I was wearing a cheap pair. You get better pairs and try and have a side seal to them, and they seem to work well. Do the glasses obstruct? No. What about air conditioning? AIR's guidelines say air handling units should have increased fresh air exchange. This is easy to do. You can go from an 80-20 fresh and recirculation to a 50-50 also if you want. And the second one says stop ventilation if feasible and for 20 minutes after the patient has left the theater. How do you stop positive pressure ventilation or positive ventilation at the theater? It is not possible to switch it off selectively. If you switch off positive pressure, you have to switch off the fan, which stops the air conditioning, which stops the air circulation, and only your exhaust is working. So there is no cooling, there's no pressure. So it really builds up the microbes in your environment, and it also builds up the heat stress. So if you have a positive pressure OT, what is important? Now, this is one guideline. There's a reason why this positive pressure thing has been mentioned, because it's part of the Indian Society of Anesthetists guidelines. But if you read a large number of guidelines, most of them say that critical times to switch off air conditioning are only when you're opening and closing doors, because that creates turbulence and the dust and everything gets aerosolized. So that is the time to switch off your AC when you're wheeling in and out patients. Also, when you finish your case, you must keep the AC on and in fact, increase the number of air cycles that are going on so that the contained air of that patient is totally recirculated, is totally removed and fresh air has replaced it. From what we hear elsewhere, most surgeons have not converted to negative pressure OTs. But is it possible to convert to a negative pressure OT if you want? Yes, it's possible. So I spoke to our AHU man and he said, yes, it's possible to do this. You can put dampers, you can put an extra exhaust. But the important part is if you are exhausting from a separate source now, that source needs to be covered by an HEPA filter. You cannot just vent out that unfiltered air. There needs to be a HEPA filter, possibly UV light at that exit. And it needs to exit 50 feet away from any air intake. You can also open the supply air duct so that extra pressure goes out. You can alter the fan speeds and change the pulleys, which decreases the power of the fan. These are not difficult to achieve, but there are solutions only for the short term. Doing a real negative pressure isolation room kind of thing requires extensive engineering, but you can do these short-term solutions. They are not possible to validate, and it does alter the airflow patterns in the OT. So this is a call that you need to take depending upon where you're practicing. What changes for the patient? He needs to wear a surgical mask. It decreases the risk if the patient coughs. It also decreases fogging, thankfully. And there are certain strategies to make the patient feel more comfortable, which I've listed. You use large drapes because you want fluid spill not to be there. And it will protect your feet and the foot switch. How does the surgical procedure change? Not really, but there are certain times of concern that I have thought about where I really don't know what the risk is, but these are times of concern. And that is because of the non-valved cannulas with VGFI systems, where we've all seen this gush of fluid that comes out when you have pressurized fluid and you remove the instruments. It doesn't happen that much with a gravity feed. It doesn't happen that much at all, actually, when you have a valved cannula. Second point is bubbling during fluid air exchange. That can happen. I don't know how much of a risk it is, but it's fairly significant at times. Spill of fluid onto the feet and the foot switch. We've already discussed strategies to combat that. And most of these are taken care of by the valve cannula. There are some concerns about diathermy, but in our case, the diathermy usually takes place in an enclosed chamber. And therefore, the risk is low. Sometimes lasers cause smoke in the vitreous cavity. I don't know how significant the risk is in that. Again, valves are an advantage here. When you're doing external diathermy, let's say you're doing a conjunctival incision or you're doing an SFIOL or something, then again, now the risk of aerosolization is very significant. So at these times, you can use a suction cannula, a general suction cannula that everybody uses, and keep that suction on to take away the smoke and the aerosols that are connected. How does the consumable situation change? So if you are really operating and considering that this is a COVID positive patient or potentially COVID positive, then anything in the OT that is lying outside could be considered contaminated, even if you haven't opened it. So if you've got a spare pair of instruments, spare suture lying around, then even though it hasn't been opened, its surface is contaminated. So you need to keep a good balance between need and excess. And how do we recycle these unopened spares? Definitely you have to wipe it down. Do you need to re-ETO it? I'm not sure, we can debate it. How does instrumentation change? A lot of your equipment is going to go into disuse because you may be running one OT when you used to be running 3. You may be doing less cases. Your rest of the machines are redundant. You cannot do simultaneous cases. So you are going to need to take care of this because these machines need to be switched on and off, and you'll have to have a servicing program in place. Expendables are going to expire because your volumes are going to go down, and this includes IOLs. This is the place where VRSI can possibly step in and be the interface between us and industry, because they say it's expired, we can't change it. So this is an abnormal situation where we will have to come to some sort of meeting ground. Resupply. Now we've given indents and supply orders for various things which the suppliers just can't supply. And we can't penalize them because they invoke the force majeure clause, in which when there are calamities, they cannot be blamed for any delay in supply. And there are situations where people will run out of things because their global supply chains are just not ready to supply them, and they are broken down, which is another great reason actually to go Indian. So you end up with this seesaw procurement where sometimes you have excess and things expiring, and then you have stock out situations. So now it's time to leave the OT after your case, and it's very important to go through the doffing procedure. This is usually a problem as it needs to be outside the OT. You can't do it in the OT because your OT is already contaminated and you need to be outside. You must have a dedicated room. You should obey the doffing sequence. There are enough videos on it. Start removing PP only after you have disinfected the outer gloves with sterilium or any alcohol-based scrub, and then remove N95 only after cleaning the inner gloves. These are just basic principles. How do we manage PPE procurement? Depends on the guidelines. It depends on institutional imperatives. And the CDC has a very nice way of doing it, in which they say, okay, if we have enough or standard strategies or conventional strategies, then we will go on this manner. And these are the people who will get this much. If you have less, then this is contingency. And if everything is over and we are swamped, then that is called crisis strategies. So it may be a good idea for all institutions to develop these 3 strategies, but this is not an escape valve for not starting at the conventional level. We have not, none of us have reached the level where we are swamped or we've hardly actually consumed our items. So we should be starting at the conventional capacity. What does this mean for our OT lists? Camps, long lists with multiple tables, finishing early, going home, low cost, these are all out of the window now. In conclusion, 1 patient per OT, designate doffing and donning areas. Non-permeable gowns are adequate body protection and are part of PPE designated by CDC, but boot covers need to be beyond the lower end of the gown. Coveralls are difficult to wear sterile. Either have a washed up assistant to help or wear a gown over it. Final configuration of PPE will depend on the practice situation, and very importantly, the acceptance and security level of the healthcare worker. The institution may say anything, the healthcare worker has to accept it. He has to feel secure in it. And that is a very difficult thing to marry up. Do a mock trial. Lot of small things will crop up. Even if you don't have a surgery, wash up, wear whatever you need to wash up, and run through a mock surgery. You'll be amazed at the number of things that develop. OT air conditioning will need to be sorted out on a pragmatic facility-based approach, depending on what's possible. Switching off air conditioning is for the duration of surgery. I don't think is a practical approach in our country. We have tried it. It was amazing heat stress. It's just impossible to do.